Have you ever been on shift and a family member comes up to you and says, "He's just not himself today"? You know that feeling. It's this vague but really urgent statement that kicks off one of the toughest diagnostic puzzles we face, trying to figure out why a patient's mental state has suddenly taken a nosedive. Today, we're going to untangle that puzzle. So, where do we start? The symptoms are all jumbled together, and honestly, the stakes are incredibly high. Is this a reversible delirium, a progressive dementia, or could it be something else entirely? Well, the very first step is to get to know our suspects. Let's line them up. So our three main suspects are delirium, dementia, and depression. And it is so important to include depression in this lineup. Why? Because in really severe cases, it can actually show up with cognitive symptoms that look a whole lot like dementia. It's a condition sometimes called pseudodementia. Each one of these has a totally unique fingerprint, and we're about to learn exactly how to spot them.
Okay, I want you to think like a detective for a second. Your first and honestly most important clue is always the timeline. Delirium, it's like a lightning strike. It's a sudden, super dramatic change that happens over hours or maybe a few days. Yesterday they were totally fine, today they're not. Dementia, on the other hand, is more like a slow-moving glacier. It's this gradual wearing away of function over months, sometimes even years. And that distinction, it's absolutely crucial.
All right, let's break this down even more, because the devil is really in the details here. Take a look at the course row. Delirium is a total roller coaster, right? The patient's mental state is all over the place throughout the day. They're up, they're down, lethargic 1 minute, and then agitated the next. Dementia is more of a steady, downhill slide. Now, check out orientation. In delirium, patients often know who they are, but they're totally lost in time and space. But someone with depression? They're typically fully oriented. It's these subtle differences that are the keys to cracking the case.
So the patient's history gives us some vital clues, but we really need some objective data to back up what we're thinking. And luckily, there's this fantastic tool we can use right at the bedside to get a quick, reliable snapshot of their cognitive function. And the best part? It only takes about 2 minutes.
This is the Mini-Cog, and it is just brilliant in its simplicity. It's so clever because it tests 2 really key cognitive areas in 3 easy steps. First, we test their short-term memory by asking them to remember 3 totally unrelated words. Then we test their complex executive function and visuospatial skills with the clock drawing task, which is, surprisingly difficult for an impaired brain to pull off. And then finally, we circle back and test their recall of those first 3 words.
Okay, time for a little pop quiz. Let's put this into practice. The scoring is pretty simple. You get 1 point for each word they recall correctly. The clock drawing is all or nothing. It's 2 points for perfect clock, 0 for anything that's not quite right. So if your patient remembers just 1 word and they really struggle with that clock, what's their total score?
Yep, the score is 1. 1 point for the word, 0 for the clock. But what does that 1 actually mean? This is where the test becomes so clinically powerful. So here's the crucial point. What is this number telling us? Does a score of 1 point us towards a potential dementia diagnosis or away from it? What's the big takeaway here? That score of 1, it's a major red flag. Any score from 0 to 2 is considered a positive screen for dementia. Now, it doesn't diagnose it, but it tells us, hey, we need to dig a lot deeper with a more comprehensive exam. On the flip side, a score of 3 or higher makes dementia much less likely. So in just 2 minutes, we've gained a really crucial piece of the puzzle. So when our investigation starts pointing towards dementia, we need to look for a much bigger, more global pattern of decline. It's not just about memory, We're looking for a whole constellation of symptoms, often called the cardinal signs, or the A's of dementia. First up, we have amnesia, the memory loss that we all associate with dementia. But it's a bit more specific than just being forgetful. It actually stems from damage to brain structures like the hippocampus. And that makes it profoundly difficult to create new memories. This is exactly why someone might ask you the same question 10 times in an hour, because for them, each time really is the first time. Next is aphasia. This is a problem with language, and it's often linked to changes in the brain's language centers. The patient might really struggle to find the right word. You know that classic tip of the tongue feeling? Imagine that happening constantly. Or they just might not be able to process what you're saying, and you can imagine this can be incredibly isolating and frustrating for them. Then we have apraxia, which is fascinating. The muscles work just fine, the person isn't weak or anything, but the brain's ability to plan and sequence a familiar action is just lost. The signal from the brain's motor planning areas gets all scrambled.
So they might hold a toothbrush, but they have absolutely no idea how to coordinate the movements to actually brush their teeth.
Agnosia literally means not knowing. This is what happens when the parts of the brain that process sensory information and connect it to meaning are failing. So the eyes see a key, but the brain doesn't recognize it as a key. This is why, and this is the most painful part, a person with dementia may eventually fail to recognize the faces of their own children. And finally, there's Abulia. And this isn't just sadness or laziness, it's a profound loss of motivation that's rooted in changes to the brain's frontal lobes, the very seat of our drive and personality. It leads to this deep apathy and withdrawal from hobbies, from friends, really from life itself.
You see, getting the diagnosis right is absolutely everything, because the treatment paths for delirium and dementia go in completely different directions. One is a sprint to find a cure, the other is a marathon of supportive care. Let's take a look at the game plan for each one.
When we're dealing with delirium, we are in full-on emergency mode. And rule number 1 is this: delirium is a symptom, it is not the disease. Our job is to be a detective and find the underlying cause. Is it a UTI? Is it a new medication? Dehydration? An electrolyte imbalance? We have to hunt for that culprit, because treating that root problem is the only way to resolve the delirium.
But with dementia, the entire approach just shifts from cure to care. The goal here is to support the patient and maximize their quality of life. We adapt the environment to meet them where they are, using things like large print clocks or labels on cabinets. And instead of arguing about what day it is, which just causes more distress, we use things like reminiscence therapy to connect with their long-term memories. It's all about preserving dignity and function.
Now, for decades, this focus on supportive care and just managing symptoms, well, that was all we had. But the landscape of direct treatment, especially for Alzheimer's disease, is slowly but surely beginning to change. This timeline really shows that journey. For a long time, we had drugs like donepezil and memantine, which help manage symptoms by working on brain chemicals, but they don't actually stop the disease from getting worse. Then, in 2023, we saw a really significant shift with the approval of lecanemab. This is one of the very first drugs designed not just to mask the symptoms, but to actually target the amyloid plaques, one of the core pathologies of Alzheimer's. And this leaves us with a critical, forward-looking question. For these new disease-modifying drugs to have the best chance of working, they have to be started early, in the mild stages of the disease. So as our tools to finally fight the disease itself evolve, how must our strategies for early, accurate diagnosis evolve right alongside them? It's really the challenge that's going to define the future of dementia care.